Hi, everybody. Welcome to our Can Chat session. Today, we will be discussing rural health, and we have some people from our very own department who will be talking to us on this subject. Before we get started, we actually have an announcement, so I'm going to hand it over to Myra briefly.
Thanks, Patrice. Good afternoon, everybody. I'm Myra Vega. Pronouns are she, her, ella. I'm the Deputy Director of Communications Planning, and I oversee the Culture Office. And I wanted to, first of all, thank you for allowing me to make an announcement. I wanted you all to know that the Culture Office is sponsoring an engagement series that is part of our learning and development plan called Community of Practice. And this is where we have professionals from within the organization. Perhaps we might invite some folks in externally down the line where we come together and talk about a topic. We are going to be piloting our first community of practice that I want to say thanks to Jolanda, Ivana, and our directorate who have supported and helped frame up this community of practice, which is going to be a rural health symposium where we will tap with the department, within the department, folks that are running programs that are focused on the unique needs of rural health. So please look out for that. That's going to be put on during the first quarter of next year. It'll be symposium style and an opportunity for you all to learn about all of the different initiatives and programs we run to help meet the needs of our rural health throughout the state. So that is it. Patrice, thank you. So more to come, everybody. Please look for information out of our culture office. Hi, Eddie, I see you. I'm glad to put a face to the name.
Thank you so much, Myra. All right, so for our agenda today, we're going to be going over 4 sections that really focus on rural health and what HCAI does within the realm of rural health. So we will be talking about the overview of California's rural health, the State Office of Rural Health, the Medicare Rural Health Flexibility Programs, and we'll be receiving a few stories about rural health and some of the changes that the systems have made to support individuals in rural areas. A quick reminder, while we're in this session, we just ask that you please raise your hand when you have a question or comment. We will be monitoring the chat so we can get to your questions very quickly. If we are in the middle of something, we might hold your question towards the end of the presenter's portion, but we will be sure to answer any questions that you have. If possible, feel free to enable your video. That way we can see your faces. And another thing is just mute your microphone until it's your turn to speak. That way we can eliminate any additional distractions. So the purpose of National Rural Health Day. So on November 21st this year, the 13th year of National Rural Health will be celebrated. So the National Organization of State Offices of Rural Health have dedicated the 3rd Thursday of November to celebrate the power of rural health on National Rural Health Day. National Rural Health Day brings attention to and honors a lot of the efforts that have gone into really supporting individuals who are in the rural health communities, the providers, organizations, and the State Office of Rural Health, and other stakeholders that have been dedicated to addressing the really unique needs of those who are in rural communities. So the National Rural Health Day really does celebrate the power of rural health. It really focuses on uplifting the efforts that individuals in the community have gathered to really commit themselves to supporting individuals in the rural health community. And also on National Rural Health Day, we recognize and we seek to address disparities in rural healthcare. All right, so just moving into our land acknowledgement. So here at HCAI in Sacramento and in Los Angeles, we really do want to acknowledge that we sit on stolen land from the Miwok, Chumash, and Gabrielino Tongva people. We believe it's really important to recall the historical truths regarding the structural, disease-ridden, ethnic, and colonial genocide to the Miwok, Nisan, Chumash, and Gabrielino Tongva people. We also want to let everybody know and acknowledge the resilience and fortitude of those and other Native people who continue to survive as cultures and communities despite efforts of genocide. Despite ongoing or the cross-generational trauma, systemic racism, and discrimination contributing to health disparities, lack of healthcare access, and barriers to entering the healthcare workforce, we still want to celebrate their perseverance. We will continue to evaluate our efforts in these areas to rectify injustices and ensure wrongs are not repeated. Again, in solidarity and allyship with Native people, HCAI commits to being positive catalysts for change and advancing our understanding of the tribal health delivery system. In doing so, we will not stand by as complicit witnesses of the injustices perpetrated throughout our history, acknowledging that inaction serves as a fuel for inequality. And again, just a few reminders. So we have community agreements that I'm sure you have reviewed if you have been in one of our Can We Chat sessions before. But just a quick reminder, Humanity First, this is going to be a safe and brave space. So we want individuals to feel free to speak up, share their perspectives, and we're going to respect perspectives here. Please remember to use I statements. All voices and lived experiences are going to be equally valued in this space. We want to listen with intent to understand and also ask for clarity. So we're not leaving we're leaving all the assumptions at the door. Most importantly, one mic, one speaker. So if it is your turn to speak, please unmute yourself so we have the opportunity to hear you. And at the same time, if you are not speaking, please mute yourself so the speakers are not distracted by any background noise. Additionally, we want to remember our last rule: what's said here stays here. And what's learned here is going to be shared with the larger HCAI community. All right, so to start with the fun, we are going to have a quick poll question. So we just really want to get kind of a pulse check on your level of understanding of rural health. So we will be sharing this poll, and you should get it popped up on your screen shortly. All right, and the question is, what is your level of understanding when it comes to rural health? Go ahead and close the poll in about 5 seconds. So if you still want to vote on it, please make sure to do so soon. All right, so we have some people who are experts in rural health, some people who don't have any prior knowledge, and some individuals who know a little bit about rural health. And that's what we're expecting. And that's why we really want to make sure that we are giving y'all vital information about rural health. Just to give everybody a little bit of background on the demographics that we're going to be talking about, we are going to be really focusing first on a comparison of the urban and rural demographics. So within rural communities, we see a higher concentration of older residents, around 26.5% of 26.5 in the rural population and about 15.4% in urban. We also see higher poverty rates within rural communities at 15.5% and 12.3% in urban areas, and this was as of 2021. And 53% of rural residents are in the labor workforce, and that's lower than what we see among urban area residents at 64%. The median household income for rural communities, or rural counties, is around $83,000 compared to about $92,000 for urban counties. And we also see that rural residents are more likely to rate their physical health as poor compared to their urban community counterparts. All right, so thank you so much, and I'm going to hand it off to my colleague.
Hi, HCAI. First of all, thank you, Patrice, for giving us that overview of the demographic comparisons and also the overview of National Rural Health Day and giving us this opportunity to share this day with all of you. Like Patrice said, National Rural Health Day always falls on the third Thursday of November. And as we all head into our own holiday celebrations, we want you to continue to remember about how much rural affects you. Most of the food that you will eat will come from farms, particularly in the farm to fork capital. from rural California. And as you finish off that class, preferably local wine, know that you too are supporting rural, and remember to join us every year as we celebrate the power of rural. My team is going to start by introducing ourselves and giving you a short overview of rural healthcare in California, including some challenges. And then we'll move on to the HCAI programs that we administer to support these communities facing these challenges. And then we'll finish up with a couple of success stories, because when you think of rural on this 2024 National Rural Health Day, we want you to think of community. Rural health above all is community. Rural health is resiliency, and rural health is innovation. So my name is Tiffany Frazier, and I am a rural health specialist here in the Office of Health, Workforce, and Development, and I am the State Office of Rural Health Coordinator.
And hello, my name is Eddie Wong. I am the Flex Coordinator for the Medicare Rural Hospital Flexibility Program.
All right, and we are a small group of 2, led by our manager, Ivan Evans. Next slide, please. So most rural counties are below the provider to population ratio and have not been able to keep pace with the growing population of insured Californians through the introduction of the Affordable Care Act. So that means there are greater numbers of people being insured and being able to access care, but not enough providers to support them. This leads us to long lead times to access appointments. It can sometimes take at least 2 to 3 months for an appointment with a specialist, and 21 or more days for an appointment to see a primary care provider. This delay in timely care results in exacerbated problems in chronic and long-term illnesses, particularly diseases like diabetes, asthma, and obesity in children. These are diseases that with proper care and treatment from a doctor can be controlled, but without the ability to receive regular timely care, they then become symptoms of larger health problems. Telehealth has seen a big boom because of the COVID pandemic and the need for it, particularly in rural health. One of the issues with telehealth is that some residents lack the ability to take advantage of the convenience of telehealth because of the lack of broadband service. So imagine for a moment that handy dandy computer that you carry in your purse or in your pocket is not available. And then imagine that you are a provider and that your patient has overcome all of these challenges to be able to take advantage of telehealth, and then not being reimbursed for telehealth visits the same way that you are reimbursed for face-to-face visits. This changed during COVID, but those exceptions are set to sunset at the end of December. But we are hoping that Congress either extends those exceptions or makes them permanent. In addition to these challenges, many of the hospitals in these communities face financial instability. These hospitals, much like the communities that they served, are often operating in the red, and somewhere around 40% are at risk for closure. Next slide, please. So how rural is California? When we think of California, we tend to think of San Francisco, LA, Sacramento, or San Diego, because let's be honest, our urban populations make us famous. But actually a majority of California land-wise is actually rural. So as you can see in these graphics, based on population, urban is king, but in land density, rural rules. There are multiple definitions of rural, and if you get 15 people in a room, you'll probably get 15 definitions of rural, unless those 15 people happen to work for HCAI. Because here at HCAI, we use something called Medical Service Study Areas, or MSSAs. MSSAs lead to easier accounting using census tracts and usually align communities with multiple similarities. And as you can see, almost half, or 42% of California MSSAs are identified as rural or frontier. So what does this mean for the rural communities that live in California? While they occupy most of the land in California, they only account for 13% of the population. And again, looking back at the demographics, over 15% of those communities live in poverty, which can sometimes lead to geographic isolation and long travel times for services. Next slide, please. Research consistently shows that rural residents experience more difficulties in accessing and utilizing healthcare resources due to various factors. We've talked about fewer numbers of providers and specialists. Now let's talk about geographic isolation, which includes the lack of vehicles and the lack of public transportation. Geographic isolation restricts mobility and leads to social and economic deprivation. Over 20% of rural residents report not having a vehicle or living in a household that has less than one vehicle per household. That means not having access to a vehicle in case of emergency. Geographic isolation can have many negative effects on the health and well-being of people, particularly older people. Older people living in these rural locations face challenges accessing services, support, and connections to their community. And in California, many rural hospitals are that only source of care for miles around, which leads us to, next slide, please.
To travel times for services. Thank you, Tiffany. So like Tiffany said, when you're geographically isolated, you're under the poverty line and you have a car deficit, travel times are a significant factor. And it's further exacerbated by hospital closures. So this quote from the California Hospital Association explains that when a rural hospital closes, the median travel distance to get inpatient care increases by 20 miles. And if you require specialist care, double that. And speaking of specialist care, let's take a service that we would likely consider necessary. Maternity wards for labor and delivery. And for this one, we have another poll question for you. Next slide, please. Say that you live in Ridgecrest, California. To put on a map, it's technically in Kern County, but it's located over 100 miles east from Bakersfield, a little bit shorter if you're going north from Lancaster. If you're driving to Ridgecrest, you're likely heading towards Death Valley National Park instead of going farther east towards Las Vegas. But either way, you are very far away from the nearest city. So our poll question for you is that you're at home in Ridgecrest, California. Right now, what is the estimated distance to the closest maternity ward? Different answers here, but we'll give it a couple more seconds for this. Let's say we close the poll in 5 seconds. All right. So I do see a majority answer of 50 miles. That's almost correct as of right now. Next slide, please. So the answer would have been 10 miles if Ridgecrest Regional Hospital has an operational maternity ward, but as of right now, that is not the case. Since March of this year, they suspended their maternity ward. The next hospital is actually 70 miles out. The top quote you see up there comes from Senator Shannon Grove, where she's saying that if you're trying to deliver a baby in Ridgecrest, quite frankly, good luck, because you're going to have to drive down a 70-mile canyon road to the nearest hospital to get there. But what if you lived in Quincy, California? In that middle quote, for a good chunk of the year 2022, Pluma's district hospital suspended their labor and delivery department. And it would be, again, a 70-mile drive down a winding forest before you can get towards the next hospital, towards the north end of Lake Tahoe into Truckee. If you've driven up to Lake Tahoe or Reno during this time of year, it is notorious for the amount of snow that can accumulate and potentially block roads to the point that you can imagine that you might need helicopter transportation. And finally, what if you lived in Imperial, California, right near border on Mexico, but 120 miles east of San Diego? Unfortunately, in 2023, as this bottom quote explains, El Centro Regional Medical Center announced their closure of their maternity ward, and now they depend on the services to their partners at Pioneers Memorial Hospital. This is the only hospital here that services a county that stretches 4,000 square miles and a population of 175,000 people. And otherwise, if they're unavailable, you're driving 60 miles towards Arizona or 100 miles toward Palm Springs. I do want to make a little sidebar here because you may have recognized some of the hospital names that I mentioned. Ridgecrest, El Centro, Pioneers. They're actually all recipients of HCAI's Distressed Hospital Loan Program. And we're happy to let everyone know again that we awarded Ridgecrest in particular a total of $5.5 million. Additionally, the hospital secured a contract with the U.S. Navy, so I'm also happy to report that they have the means to reopen their maternity ward as of next month. But all of these critical access hospitals are the ones that we want to keep supporting. And the challenges that we covered are just some of that rural California faces. So our office, the California State Office of Rural Health, we aim to help them. Next slide, please.
All right, now let's talk about some of the resources that HCAI provides to support these communities. Next slide, please. So the California State Office of Rural Health, or SOAR, is a federal state partnership between the Health Resources and Services Administration, the Federal Office of Rural Health, FORB, and HCAI. Since 1991, FORB recognized that the best way to assist states in strengthening rural healthcare delivery systems is by maintaining a focal point for rural health in each state. Each state has their own unique needs, and this program provides the funding that links rural communities with state and federal resources to develop long-term solutions to rural health programs. Now, if you've been at HCAI for a while, you might be wondering, if this program has been around since 1991, why have I never heard of it? Well, don't beat yourself up too much. Like our name, HCAI, CalSOAR is new. In 2022, CalSOAR was moved from DHSC to HCAI to better align its program activities and to collaborate with our other federal state partnership, the Primary Care Office. The general purpose of SOAR is to help rural communities build and maintain reliable healthcare delivery systems. And as such, a SOAR is expected to collect and disseminate information regarding rural healthcare issues, innovative approaches to the delivery of healthcare in rural areas, coordinate rural healthcare activities in order to avoid duplication, and lastly, to identify federal and state programs regarding rural health and provide technical assistance to public and nonprofit private entities regarding participation in such programs. SOARs may also conduct activities pertaining to recruiting and retaining health professionals to serve in rural areas of the state and provide contracts to public and nonprofit private entities to carry out SOAR activities. Next slide, please. So here we're going to have another poll question now that you learned a little bit more about what SOAR does. Can you tell us which of the following programs might fall under the California State Office of Rural Health umbrella? Is it okay. So first we have the Medicare Rural Flexibility Program, the J-1 Visa Program, the Small Rural Hospital Improvement Program, or all of the above. So I'll give everyone a minute to answer. Okay, so it's looking like responses have kind of slowed down. And so it looks like most of you put all of the above, and yes, you are correct. So next slide, please. Here you will see under the SOAR umbrella, you will find all 4 of these programs. First up is the Medicare Rural Hospital Flexibility Program that supports critical access hospitals, or CAHs, and you will learn more about this program in a moment. All of our J-1 visa programs that allow foreign-born/educated doctors to stay in the country and continue to provide medical services to underserved communities. And the Small Rural Hospital Improvement Program, SHIP, they offer grants to eligible hospitals to assist in meeting value-based payment and care goals through investments in hardware, software, and training. A small rural hospital is defined as a hospital outside of a metropolitan statistical area or in a rural census tract of the MSA. It must be a non-federal, short-term general acute care facility and staff 49 or fewer beds. So if you take one thing from this webinar, let it be this. All CAs are ships, but not all ships are CAs. This information, along with $7 to $8, will get you a coffee at any Starbucks in the country. Sorry, okay, sorry, moving on. My apologies, I couldn't resist. So the final slew of programs under CalSOAR are our contracted partners. The California Telehealth Resource Center, which provides education and resources to rural communities. They're also creating a rural health advisory team that will focus on telehealth issues and trying to find solutions to those issues. The Area Health Education Center, or AHEC, is working with residents and residency programs to create an educational program that provides information on creating resilience and preventing burnout for practicing physicians. And OBPH is a collaboration with CDPH and the Office of Binational Border Health, and they provide educational opportunities for community health workers to support our migrant farm workers. Next slide, please. These are some of the projects that we will be working on in the upcoming year. Most of these activities are rooted in building relationships with the rural healthcare community, ensuring that they know that our programs are available. For example, last year, as Eddie said, HCAI offered the distress loan program, which many of the hospitals took advantage of. But shortly after the loan closed, we received information that one of our hospitals was indeed in distress and in danger of closing. So when we asked them why they didn't apply for the distress loan program, they said it was because they didn't think that they would ever be in a position to pay the loan back. These are some of the issues that we would like to be able to create a bridge for. And even though perhaps the distress loan payment program might not be the right funding for that hospital at this time, there are many more opportunities for them to get funding, and we want to open up those lines of communication. Next slide, please. Here are some links to our rural health partners if you'd like to learn more about the programs that I spoke about here. I also added our CalSOAR email address in case you have any questions that we may not be able to get today, or you would like to collaborate or join in with us on any of our projects. We'll be excited to have you. Next slide, please.
Thank you again, Tiffany. So we're at the Medicare Rural Hospital Flexibility Program, one of the programs under the State Office of Rural Health. But for this, we just call it the Flex Program. Next slide, please. So the Flex Program actually goes back to the Clinton administration. Following an alarming chain of rural hospital closures in the late 80s and 90s, the administration passed the Balanced Budget Act of 1997 to help rural hospitals across America. Now, there are two important things that were established to do this: the power to designate certain rural hospitals as critical access hospitals, and the creation of the Flex Program, myself, to provide them technical assistance. We'll get to the specifics in a bit, but we have one final poll question for you. Next slide, please. Just for fun, we'd like to have you make your best guess on how many critical access hospitals we have in California. Bring that poll up right now. Awesome. Thanks. Thank you so much for participating in the poll. We'll close it in about 10 seconds. All right. So the majority, I see, answered 38 hospitals. And you're actually right. We have 38 critical access hospitals in California. But the other answers aren't just for show. 13 critical access hospitals are in Nevada. Montana has 50 and Texas has 91. So critical access hospitals. Next slide, please. If you happen to be at a critical access hospital, congratulations. You are at the nearest hospital within a 35-mile radius of another one. They're there to provide 24/7 emergency care. And with up to 25 acute care inpatient beds, they can take in patients for an average length of 4 days. As a critical access hospital, they can receive cost-based reimbursement through the Medicare program, meaning that at the time of the act's inception, they could have received up to 101% reimbursement from Medicare for allowable costs. But this alone wouldn't support a hospital. And for certain hospitals with struggling finances and operations, the ones that Tiffany was talking about before, they could still be in the red. Hence the Flex program. Next slide, please. As Flex coordinator, I am there to provide support to all 38 critical access hospitals. The Flex program is exactly as it sounds. We provide flexible guidance as needed, depending on the hospital situation, because the Act understands that every state has their own situation with their critical access hospitals. We help them on activities such as quality, financial, and operational improvement. But there are other fundamentals that we cover. So in this slide here, after we secure the funding through the Health Resources Services Administration, HRSA, their grant application, so that we can do what we do, we, along with the partners at the California Hospital Association, help keep hospitals appraised of trends, financial data, legislative updates, and workshops. All the while, we at HCAI keep HRSA updated on those activities and efforts. There's actually a workshop that was hosted right here at home in HCAI where we contracted with Strawbell to teach hospitals about cost reporting. And the last part right there, the data collection project, is something that we came up with ourselves because actually the Flex program was passed to us from Department of Healthcare Services in 2022. We aim to evaluate our current data resources and to figure out the best way to present them to hospitals so that it's useful and perhaps critical to their success. Next slide, please. So we do share a number of partners with the SOAR office. And I do want to point out how awesome it is that the Flex program is set up on a national level with the amount of partners that exclusively focus on cost. The Flex monitoring team, in particular, they're a collaboration between 3 universities, the University of Minnesota, University of North Carolina at Chapel Hill, and the University of Southern Maine. They're responsible for a lot of the data reporting that we use today and to provide technical assistance for those hospitals. So to shift gears one more time, I'll hand it back to Tiffany for some rural health stories that we've compiled. Next slide, please.
Thanks, Eddie. Next slide. One of the best parts about my job is going out into the field and seeing the work that we do put into action. When we visit these hospitals, we get to meet the doctors, nurses, and admin professionals that are boots on the ground every day. Many of the employees that we speak with have worked at these places for multiple years and are still passionate about the work that they do for their community. It was here at Mark Twain where the vice president actually started out as a medical assistant, and through the hospital's teacher-owned program was able to work their way up to vice president. I also spoke with a dentist that was a state loan recipient over 20 years ago. They finished their contract and moved to private practice, but they hated it and went back to the site where they completed their loan repayment and have been working there ever since. And that was over 20 years ago. These are rural health stories, and this is the power of rural. Next slide, please. So no rural health story would be complete without at least mentioning the social determinants of health. So social determinants of health are the non-medical factors that influence health outcomes. One of them is a lack of transportation that we spoke about earlier, and another is access to housing. This hospital, Adventist Health, clearly is creating Project Restoration and Hope Center, which are 2 supportive housing facilities started and run by the hospital. They receive grants from HUD and are constantly looking for other funding opportunities to support programs that include housing, housing navigation, recuperative care, and short-term post-hospitalization. Next slide, please. So the focus this year of our federal teams is maternity health. So we chose two maternity health success stories to share with you. The first is about a team of angels at Southern Lakeside Hospital. This story starts with a young woman who is 22 weeks pregnant with her first baby. She has already been experiencing 3 days of abdominal pain that she had been evaluated in her hometown by her normal physician. While visiting Lake County, she fainted and lost consciousness and was rushed to the emergency department. The emergency department team initially thought that it may have been related to heat and dehydration. However, treatment efforts and further evaluation revealed that she had a ruptured splenic aneurysm. So immediately, Sutter activated the all hands on deck massive transfusion protocol and prepped her for surgery. Fortunately, excellence and teamwork kept her alive through some very unstable moments, giving their surgeon enough time to stop the bleeding. In less than 10 minutes from time of incision and just past midnight, she was then transferred to Sutter Santa Rosa Regional Hospital to continue treatment for mom and baby. When the team heard the news about the survival of the baby from Sutter Santa Rosa and the accolades from the parent calling everyone here at Team of Angels, tears were definitely shed. And this is why we are all in for Lake County and Sutter Health, especially here at Lakeside Hospital. And that's a direct quote from Sutter Lakeside. Sutter Lakeside is a leader in maternity health, even in rural California, and we want to make sure that these stories are able to continue going, because without that hospital being there and that maternity ward being open, we might have lost mom and baby. Next slide, please.
And here's the other story I wanted to share, also from Sutter Lakeside. Just to let you know that these slides up here, we posted the whole story. But for the purposes of the presentation, we'll summarize it here, but it will be available for you in the near future for your reading pleasure. So this story is also a maternity health story from the Sutter Lakeside. And the long and short of it is that a pregnant woman, she's 39 weeks along. She went to Sutter Lakeside for delivery. But what started as a routine process quickly spiraled when the mother had a sudden seizure. She was losing consciousness quickly, and the baby's heartbeat grew weaker. So the hospital had to rush them to the operating room for a C-section. Now, while the baby was successfully delivered, both the baby and the mother were in critical condition. The mother more so. The amniotic fluid that would suspend and support the fetus entered the mother's bloodstream, which led to massive bleeding and cardiorespiratory collapse. It's one of the leading causes of maternity deaths. So the hospital split into two teams to save both the mother and the baby. And after several harrowing hours, the mother was finally able to see her child. So this story here and the one that Tiffany shared, these stories are here to say that the mothers and their babies, they needed that hospital staff. They had to be there because so both could survive. And medical services like these are critical, vital to any community. So our office does the best we can to ensure rural hospitals are equipped to support themselves and keep medical service like these operational. Next slide. So we are actually at the end of the presentation. Thank you so much for your time and for having us. If you require more information on the statistics that we presented, we also have a slide here with the links for you. And if you'd like any more information and there are any further clarification on the data that we shared with you, feel free to contact us directly. Thank you again. Back to you, Patrice.
Thank you, Eddie. All right, so